Hello, this is Lee Learman from the Florida Atlantic University, and I will be presenting a short overview of perinatal depression screening and diagnosis for our flipped classroom. This will be the first of two short presentations. Our objectives will be to cover screening guidelines and tools, go over important diagnostic considerations, as well as key points to include in patient education. Major depressive disorder is one of the most common disorders in women and is a part of a family of depressive disorders listed here from the DSM-5 reference. Peripartum depression is simply major depressive disorder timed in the peripartum period. It otherwise shares the features of the diagnosis found outside of pregnancy. It is one of three common postpartum mood disorders, the blues being the most common and psychosis being quite rare, as depicted in this table. And like other major depressive disorder, peripartum depression must meet the established criteria of the DSM-5, which are listed here. One of two major criteria, depressed mood or anhedonia, that is a lack of interest in the things that are normally pleasurable, as well as other symptoms adding up to 5 out of 9, all present for the same 2-week period. There are many risk factors for major depressive disorder, including ones we see commonly in pregnant women, including women from low resource backgrounds, those with chronic diseases, those with a history of depression, or having had a recent loss or traumatic event. There are also clinical signs that would make us more suspicious. Patients who have multiple visits for vague complaints, those that act and look as if they're depressed, those who come in with pain syndromes, a common comorbidity of which is depression, and something I've termed the dementor effect, feeling that all of the joy and energy has been sapped from you after having met with a patient, and you are inexplicably feeling tired and weak after that interaction. This is the synchrony we use with our patients emotionally, and as a result of their depression, we come out feeling a little bit depressed after we meet with them. So if this happens to me and I'm feeling that way after leaving a patient's room, if I haven't already, I think of screening them for depression. There are screening guidelines that are available for us, and some have been recently updated. The ACOG Well Woman's Task Force in 2015 recommended annual screening for depression using a validated tool, and recommended screening postpartum women for depression also using a validated tool. A very recent update from the U.S. Preventive Services Task Force recommends screening for depression in the general adult population, including pregnant and postpartum women. In a hopeful comment, the task force would prefer that screening be done with adequate systems in place to ensure diagnosis, treatment, and follow-up. This is a controversy that the task force had to deal with because in many settings these resources are not available. And the thought was perhaps we shouldn't be screening women for depression if we don't have adequate systems. However, the task force recently changed this to promote screening and recommending adequate systems, but not requiring them as a prerequisite for screening. The Well Woman Task Force developed some additional guidelines based on uniform expert opinion. Do not deny screening because of any limitation of local resources, but do have plans for referral. Develop initial management skills that are within the scope of the specialty, including limited counseling and pharmacotherapy, and the patients should be counseled about the limitations of local resources. These are the caveats that go along with the recommendation to universally screen in settings that may not have adequate resources. There was an initiative sponsored by the MacArthur Foundation to promote depression screening in primary care, and it generated an extremely helpful toolkit from the initiative, which is linked here. It was initially published in 2004 and updated in 2009. It includes several important appendices that are listed here and provide very useful tools for us to use as part of our treatment and management of depression. I'll show it to you here on the screen just to give you a sense of what it has in it. It's a wonderful resource with an elaborate table of contents, a systematic approach to depression care processes, and very specific appendices going over recognition and diagnosis, patient education, treatment, etc. This is something that I have used in the past very successfully and would recommend it highly to those of you who would like to do your best in a primary care setting with the management of depression. In the first step of the MacArthur Initiative's process, they focus on recognition and diagnosis and recommend early referral for any of the following symptoms or situations. There will be later times that we consider referral for lack of improvement and other things, but it's very important early on to recognize any of these particular conditions as an indication for immediate referral and assessment. We should know where to send folks in terms of psychiatric emergency services and be ready to refer them if any of these are present. Postpartum depression can be screened easily using a number of different tools. For those that are not needing immediate assessment, we have time in our practices to ask them several questions that are easily provided in published screening tools. The most common use in obstetrical practices traditionally has been the Edinburgh Postnatal Depression Scale with its 10 items, takes less than 5 minutes to complete, has reasonable sensitivity and specificity, and is available in Spanish. However, I use the Patient Health Questionnaire 9, the PHQ-9, which is the same tool we use outside of pregnancy with its 9 items. It takes just as long as the Edinburgh to answer, has better sensitivity and specificity, and is also available in Spanish. These other ones also work well, but they are longer. They have a variety of sensitivities and specificities, and therefore, if I had to pick two to choose from, it would be the Edinburgh or the PHQ-9 as the most efficient and effective screening tools for depression. There's a shorter version of the PHQ-9, a 2-question screening tool. You can see the 2 questions here correspond to the 2 hallmark symptoms of depression. If you don't have either one of these, you virtually can't be depressed. So here the PHQ-2 score of 1 or more corresponds to an increasing likelihood of major depressive disorder, as listed here at the bottom of the table. And this could be used as initial screening, followed by the full PHQ-9 to get a better sense for all of the depressive symptoms. However, in my practice, because a lot of my patients have risk factors for depression, I go ahead and just do the PHQ-9 at the outset. In the PHQ-9, it's very simple to answer. The scores range from not at all to nearly every day for each of the 9 symptoms. A score of greater or equal to 10 makes major depression a likely diagnosis, and then one can score it as mild, moderate to severe based upon the total points that are scored. As we also ask with PHQ-9 how difficult it is for these problems in terms of quality of life and the ability to function with daily activities. The major depression assessment following the positive screening result would include reviewing the history of present illness for precipitating events, any stressors or losses, to review the symptoms of mania and hypomania. If the patient has pressured speech, grandiosity, and other signs of mania, we might consider bipolar disorder, which is very important to identify early because the treatments for bipolar disorder are quite different than those for major depressive disorder. Any symptoms of mania or hypomania should prompt a referral for additional diagnosis. A history of prior depression, treatment, hospitalization, all of that should be ascertained. The impact of the symptoms on quality of life, any comorbidities as listed here, and reviewing medications to be sure that this might not be a side effect of medication use. We also would pay attention to the potential presence of diabetes and hypothyroidism, as many nonspecific symptoms of these disorders overlap with those of major depressive disorder. We would go on to do a family history, social history, a mental status exam to assure the patient has adequate cognitive functions, a very targeted physical exam based upon what we yield from the history, and then a very small group of laboratory tests as indicated by the H&P, which might include a CBC looking for anemia, a chem panel looking for metabolic disorders, a thyroid screening or analysis, a pregnancy test for someone who is not yet pregnant, and a tox screen if we suspect substance abuse. Every patient suspected of depression should be screened for suicide. We can do this without worrying about causing the patient to consider suicide or increasing their chances of becoming suicidal. It is safe to assess for safety. Have you had any thoughts of hurting yourself? Do you sometimes wish your life was over? And if they answer yes, do you feel that way now? Do you have a plan? Do you have the means to carry it out? Do you have any guns in the house? Do you promise to call me immediately if your thoughts get stronger? These are the common ways to assess for safety in a patient who you suspect may be depressed. It's time to request an emergency psychiatric assessment when you are in doubt, if you feel psychotic symptoms are present, if there's any substance abuse, a strong plan or impulse, lack of sufficient social support, or unsafe living situation. This would be the second time to consider psychiatric assessment. We already discussed the initial criteria a little bit earlier in the presentation. Step 2, according to the MacArthur Foundation, is patient education. The patient needs to be informed about her diagnosis, the care process, treatment options, and her preferences for which way to move forward, through psychotherapy, medication, or both. We have to be prepared for patients to be very skeptical, and we have to figure out ways to explain why we do not think it is all in her head. One of my colleagues likes to say that depression is like throwing gasoline on a fire. Whatever symptoms you may have, it makes them feel a whole lot worse. So why wouldn't we put out the fire? Why wouldn't we stop the gasoline from pouring onto the fire? I use a story of two women who came to the emergency room with a broken arm. One is depressed and the other is not depressed, and I ask the patient to tell me who has more pain in her arm. I wait until she tells me the depressed patient, and then I answer, it doesn't mean she doesn't have a fracture. And this is a way to reassure patients with physical symptoms that she may have depression and a physical explanation for her pain or whatever her symptom may be. The later referral criteria include patient request, current substance abuse, safety, issues that had not been identified earlier, or partial or failure to respond to medications, so that you can see there are 3 different phases at which a psychiatric referral may be needed. Fortunately, a lot of our patients do not have any of these criteria and can be safely managed within our own practice. If we need to refer a patient, we would explain the reasons why. It would be very important to emphasize that we are not walking the patient to the door and saying goodbye. We will remain involved in her care, and to validate that depression is an illness. It is not her fault. It is common. She is not crazy or to blame. We just need some help in helping her because our skill set doesn't give us all that we need to help her with her depression. So this concludes the first of our 2 short presentations for our flipped classroom on perinatal depression. We'll consider management of depression